Dr. Chitra, your mentor at StudyMEDIC and StudyMRCOG, and today we are going to revise the topic endocrinology. So this is the rough distribution of what percentage of questions you would expect from endocrine. So remember, endocrine is a huge chunk in your paper 1. Expect something around 15 to 20 questions from endocrine. So let's begin. I want you to pause the video here and think of what all are the nuclei in the hypothalamus and what hormones do they secrete. When you are done, let us see the answers. So the paraventricular nuclei, they secrete CRH and TRH, arcuate nuclei, dopamine, GHRH, GnRH. GnRH is also secreted by the preoptic nuclei. The periventricular nuclei secrete somatostatin, and ADH and oxytocin is secreted by the supraoptic and paraventricular nuclei. This is an important slide. Please go through it again because you can expect at least one SBA from here. So a typical question that would be asked is, which part of the hypothalamus produces antidiuretic hormone? Or to confuse you, they might ask you that where is the antidiuretic hormone produced in the brain? They would be giving you an option of hypothalamus, anterior pituitary, posterior pituitary, or many more options. Remember, ADH is produced in the hypothalamus but is stored in the posterior pituitary, and after the appropriate stimulus, it is only released from the posterior pituitary. Posterior pituitary does not produce the antidiuretic hormone. Now, in the hypothalamus, the supraoptic and paraventricular nuclei are the nuclei responsible for secreting antidiuretic hormone. Alright. Now coming to the pituitary. So we know there are acidophils and basophils in the pituitary, and they secrete the various hormones. Now remember, acidophils, they secrete only growth hormone and prolactin. The commonly asked questions nowadays is, what is the percentage of somatotrophs and mammotrophs? So remember, somatotrophs, they target the largest system in the body, so they make up about 50%. Mammotrophs target only the breast, which is comparatively a smaller tissue, and the percentage is 20%. Coming to basophils, which secrete ACTH and MSH, TSH and FSH and LH. So corticotrophs make up about 10%. Thyrotrophs, which target the thyroid, it's a comparatively smaller tissue, so only 5%. And gonadotrophs, targeting the gonads, they make up about 20%. Another very important slide because this is a frequently asked question nowadays. Now coming to the hormones. Okay, so for growth hormone, they are going to ask you which are the stimuli for release of growth hormone and which of the stimuli will have a negative feedback. So remember that the growth hormone, it is secreted in response to sleep whenever there is hypoglycemia and whenever there is stress. These are the positive feedbacks for release of growth hormone, and the negative feedback is somatostatin. It is an inhibitor for secretion of growth hormone. Okay. The other hormones secreted by the anterior pituitary, FSH and LH. Now you have to know that FSH and LH, they act on the ovary, but which are the cells in the ovary which have receptors for FSH and LH? In the ovary, you have theca cells and you have granulosa cells. Now remember, LH hormone, it acts on the theca cells as well as on the granulosa cells. Okay, so in the theca cells, LH is responsible for secretion of progesterone. This progesterone then crosses over to the granulosa cells, and then you get a formation of again estradiol. Okay, so LH basically has receptors in the theca cells as well as in the granulosa cells, whereas FSH has receptors only in the granulosa cells. Okay, the theca cells, they produce progesterone as well as testosterone. This testosterone, it crosses over to the granulosa cells and there it is aromatized to form estradiol. This is happening in the ovary. Now what happens in the testis? In the testis, LH has effect on the Leydig cells. Remember L for L. And in the Leydig cells, it brings about production of testosterone, which is then converted to dihydrotestosterone. This dihydrotestosterone crosses over, and in the Sertoli cells, it stimulates spermatogenesis. In the testis, FSH acts only on the Sertoli cells. It does not act on the Leydig cells. The next important hormones that you have to be remembering are the thyroid hormones. Most importantly asked is, what are the thyroid changes in pregnancy? So remember that because of the increased vascular supply, there is a moderate enlargement of the thyroid gland and also vascularization is increased. The most important thing you have to be knowing is what happens to TSH levels in pregnancy. So remember, TSH and beta HCG, they share the alpha subunit. So because beta HCG is increased in pregnancy, because of the structural similarity, TSH secretion normally decreases in the first trimester. And in cases where you have too much of beta HCG, like in hyperemesis, whenever there is a multiple pregnancy or there is a molar pregnancy, you can have biochemical hyperthyroidism. That means because of the structural similarity, TSH secretion is decreased. Okay, but in the second and third trimester, when the beta HCG levels are low, then TSH comes down to normal levels and then it is within the normal ranges of pregnancy. During pregnancy, there is increased level of circulating thyroid bound globulin, and because of this increase in TBG, total levels of T3 and T4 will increase in pregnancy. So why is this important? Remember that in pregnancy, whenever you want to diagnose a thyroid condition, never do total T3 and T4 levels. Always go for free T3 and T4 levels because these are not going to change in pregnancy, and if you have a change in free T3 and free T4 levels, then you know that this is not a physiological change in pregnancy and there is some thyroid disorder that is happening. What about iodine? Because there is increased renal clearance during pregnancy and also the fetal uptake of iodine increases in pregnancy. That is why levels of iodine decrease in pregnancy, the maternal levels. Okay. Now for the fetus, remember that the fetal thyroid, it starts concentrating iodine, and synthesis of thyroid hormone starts as early as 10 to 12 weeks of gestation. Alright. The important disorders that you need to remember about the thyroid gland are hypo and hyperthyroidism. A common question that would be asked would be like this, that a woman presents to the GP having galactorrhea for 2 months, otherwise she is fit and healthy, she is not on any medications, there is no abnormality seen, and her hormonal profile is like FSH and LH is in the normal range, estradiol is a little bit decreased, TSH is markedly raised, free T4 is in the normal range or slightly decreased. So what could be the most likely cause? Pause the video here, think of what could be the likely cause. It's obvious here that TSH is markedly increased. Even though they have not given you the normal ranges, a TSH of 15 is not going to be normal in any case. So the most likely cause that is responsible for this woman's condition is hypothyroidism. Alright, because all the other hormones, they are grossly in the normal range, whereas TSH is grossly elevated. Okay. Now the next common question that is asked is, what is the most common cause of hyperthyroidism? So remember, in pregnancy and overall, the most common cause of hyperthyroidism is Graves' disease. And what is it characterized by? There is a small goiter which is small to moderate. Okay, so most common cause of hyperthyroidism is Graves' disease. And it is an autoimmune disorder. The next common question that is asked is, worldwide, what is the commonest cause of hypothyroidism? Listen carefully. Worldwide, what is the commonest cause? So if you get it as worldwide, the commonest cause is iodine deficiency worldwide. But if the question is asked is, what is the commonest cause of hypothyroidism in UK or in the developed countries? Remember, it's going to be Hashimoto's thyroiditis. So worldwide, it is hypothyroidism. In developed countries or in countries like UK, it is Hashimoto's thyroiditis. Okay. Now next, coming to the parathyroid gland. So two hormones that you should be remembering is, let us see first calcitonin, which is again secreted by the thyroid gland. It is secreted by C cells of the thyroid gland. And what is the main action of calcitonin? So remember, it is tone in. That means it tones down the levels of calcium. So it decreases the level of calcium in the blood. Now how does it do that? Because it has to decrease the levels of calcium in the blood, naturally absorption from the intestines is decreased, or it inhibits calcium absorption from the intestines. To decrease levels of calcium in the blood, what does it do? It moves calcium from the bloodstream into the bones. So it stimulates osteoblasts and it inhibits osteoclast. And again, it has to decrease calcium levels in the blood. So what does it do? It will inhibit reabsorption of calcium in the urine. Or what happens is, more amount of calcium is excreted in the urine and less is reabsorbed in the kidney. So less reabsorption occurs in the kidney. That is why more of calcium gets excreted in the urine. Next, coming to the parathyroid gland. So remember, parathyroid hormone, the action is opposite to that of calcitonin. So what it does, calcitonin decreases the level of calcium in blood, whereas parathormone, it increases the level of calcium in the blood. So what will it do? Okay, you have to remember, increase the level of calcium in the blood. So it will stimulate the osteoclasts. So the calcium from the bone, it goes into the bloodstream. And in the small intestine, what it does is, it will increase absorption in the small intestine. So the level of calcium in the blood increases. And what does it do in the kidney? In the kidney also, it will decrease excretion of calcium in the urine. Okay, so by all these mechanisms, parathormone, it increases the levels of serum calcium. Now what about phosphate? Remember, both parathormone and calcitonin, they decrease the level of calcium in the blood. So the phosphate are decreased by the action of calcitonin as well as parathormone. The only hormone that increases the level of phosphate is vitamin D. It leads to increased phosphate reabsorption in the kidney. Next, commonly asked questions are pancreatic hormones. So in the pancreatic hormones, you need to remember about insulin and glucagon. So the green part, it shows glucagon, and the red one, it shows insulin. Okay, insulin, we know this hormone very commonly right from our first MBBS days. Insulin, the stimulus for insulin is high glucose levels. So what is the function of insulin? It will decrease the level of glucose into the blood. So what does that? How does it do that? It will promote the uptake of glucose in the peripheral tissues. Okay, so if more glucose goes into the peripheral tissues, the level of glucose in the blood goes down. The other thing that insulin does is, it stimulates glycogen formation, and then this glycogen, it gets stored in the liver. So two mechanisms: increased uptake in the peripheral tissues and storage of glucose in the form of glycogen in the liver. Okay, and stimulus for insulin is high glucose levels. The other hormone secreted from the pancreas important is glucagon. The action or the stimulus for glucagon is exactly opposite to that for insulin. Now, whenever there is hypoglycemia, that is a very potent stimulus for secretion of glucagon. So obviously, the action of glucagon is to raise blood glucose levels. Glucagon mainly acts on the liver. It breaks down this glycogen into glucose. The process of this is called as glycogenolysis. Okay, so glycogen is broken down into glucose, and this brings about increase in the blood sugar levels. So this is glucagon. Okay, and obviously both of these hormones, they inhibit release of the other hormones. Other very important hormones asked are hormones from the adrenal cortex. Okay, so we know there are 3 layers in the adrenal cortex: glomerulosa, fasciculata and reticularis. Glomerulosa secretes mineralocorticoids, fasciculata glucocorticoids and reticularis weak androgens. Pause your video here for 2 minutes. Go through this slide. It will give you everything that you need to know about adrenal hormones. 2 important disorders that you need to know about adrenal cortex: Addison's disease and Cushing's. So Addison's, basically it is decreased or deficiency of hormones released by the adrenal cortex. So you will have low mineralocorticoids, low glucocorticoids and less of the androgens also. The clinical features: there will be hypotension, hyponatremia, hypoglycemia, hyperkalemia and hyperpigmentation. So if you remember this picture of a very frail lady with hypoglycemia and hypotension, you will remember Addison's disease very nicely. Now remember, there is deficiency of mineralocorticoids. The most important function of mineralocorticoids is to reabsorb sodium and water. Because there is deficiency, there is no reabsorption of sodium and water. There is deficiency of sodium as well as water, which will give rise to hypotension. There are no glucocorticoids, so less of glucose, that will give rise to hypoglycemia. And remember, sodium and potassium, both of these are positively charged ions. Now whenever there is deficiency of sodium, which is a positively charged ion, to compensate for this, the other positively charged ion or potassium, that is retained by the body. So in Addison's, there is less of sodium and more of potassium, leading to hyponatremia and hyperkalemia. The next important syndrome or disease that you have to remember is Cushing's. Now this is opposite to that of Addison. Here you have too much of adrenal hormones. So there are more mineralocorticoids, more glucocorticoids. Excess of glucocorticoids will cause hyperglycemia or will lead to diabetes. Too much of mineralocorticoids will cause retention of sodium and water, giving rise to hypervolemia, hypertension and hypernatremia. So in Cushing's, there is too much of sodium being retained by the body. So to compensate for that, all the potassium is going to be excreted, and that leads to hypokalemia in Cushing's syndrome. Okay, remember 2 things: Cushing's syndrome and Cushing's disease. Now whenever you have symptoms which are because of these symptoms, because there are more of adrenal hormones, because of more ACTH being secreted, then it is called as Cushing's disease. Okay, like the pituitary is secreting too much of ACTH, and because of the increased ACTH you are getting Cushing's features, then it is called as Cushing's disease. Whereas the increase in the adrenal hormones it is independent of ACTH, then it is called as Cushing's syndrome. So whenever there is a central cause, it is Cushing's disease. Whenever it is due to an adrenal neoplasm or iatrogenic supplementation of steroids, then it is called as Cushing's syndrome. And iatrogenic supplementation of steroids, that is one of the most important reason of Cushing's syndrome. The next system that you should be knowing is the renin-angiotensin aldosterone system. Only in one slide, because it is basically a very simple system. It helps to regulate the blood pressure. Okay, so the most important stimulus for the activation of this renin-angiotensin system is a drop in the blood pressure or a drop in the fluid volume. So whenever you have hypotension or whenever you have hypovolemia, renin is released from the kidney. Now this renin which is released from the kidney and angiotensinogen which is released from the liver. So this angiotensinogen, it acts on the renin and forms angiotensin 1. You have angiotensin converting enzyme which is released from the lungs. This ACE acts on angiotensin 1. It converts angiotensin 1 to angiotensin 2. Now it is this angiotensin 2 which will act on the adrenal cortex and brings about release of aldosterone. Aldosterone, we know, it is the most important mineral corticoid in the body. This aldosterone, it acts on the kidney and it brings about reabsorption of sodium and water, and then it restores the blood pressure and the hypovolemia. Angiotensin 2 has another function. It is a very potent vasoconstrictor. So because it is a vasoconstrictor, it helps to maintain the blood pressure. So good. This is your renin-angiotensin aldosterone system in one slide. Now next, coming to the sex hormones. So we know everything about estrogen and progesterone. I'm not going to elaborate on that. Typical questions asked is about which hormone is going to be typically raised in which day of the menstrual cycle. So if you have a lady with a 28-day menstrual cycle, which hormone would typically reach its peak level on day 21 of the cycle? Pause the video here, think about the answer and then click. So the answer here is progesterone. Okay, which we know progesterone is going to be secreted only after ovulation and it reaches its peak on day 21 or in the middle part of the luteal phase of the cycle. Okay, all the other hormones, they have their peak before ovulation, and testosterone, we know there is no relation to ovulation. So if you remember this figure, it is going to give you an idea about which hormone is going to be raised in the mid-cycle and which hormones they are going to have their peak later on. Okay, so remember, LH is the one that is going to have a peak just before ovulation. After ovulation, LH goes down dramatically and it is progesterone then which is going to have the peak later on. So this is your LH, which is having a peak just before ovulation. Progesterone, it's having a peak after ovulation or about day 21 of the cycle. FSH, we know there is a peak here because it is responsible for stimulating the ovary to produce follicles, and this is your estradiol, again having a peak pre-ovulatory, and then the levels are slightly low than progesterone. Next, coming to congenital adrenal hyperplasia. A lot of questions are asked, and then so remember, what is congenital adrenal hyperplasia? It is basically a rare autosomal recessive disease, and it is because there is deficiency of some of the enzymes which bring about production of mineralocorticoids, glucocorticoids in the adrenal gland. Okay, so which are these enzymes? 21-hydroxylase is the enzyme which is responsible for congenital adrenal hyperplasia in 90% of the cases. The second commonest is 11-beta-hydroxylase, and very rarely you get deficiency of 3-beta-hydroxysteroid dehydrogenase. Let us see what is the pathophysiology. Okay, so remember, this is your adrenal cortex. The main source of mineralocorticoids, glucocorticoids and androgens is testosterone. You need not remember all the steps. Just remember that cholesterol gets converted to aldosterone, which is the main mineralocorticoids, cortisol, which is the main glucocorticoid, and testosterone and DHEAS. Okay. So if you have a block in any of the enzymes here, let us see what happens. Okay. So we saw that the commonest enzyme which is deficient is 21-hydroxylase. So if there is a block here, there is no 21-hydroxylase, all this cholesterol that is here, it is going to get converted into testosterone and DHEAS. So what is going to happen in a fetus is that if it is a female fetus, because of excess of androgens, you are going to get ambiguous genitalia. And at birth, remember, 21-hydroxylase deficiency leads to severe hypovolemia, salt wasting and severe hypoglycemia. So if it is not diagnosed at birth, if steroids are not replaced, then it is going to lead to death. Okay, so 21-hydroxylase deficiency basically leads to salt wasting, so hypotension, hypovolemia, no glucocorticoids, so severe hypoglycemia, ambiguous genitalia in a female fetus, and if not diagnosed at birth, it can lead to death. Okay, so this is your 21-hydroxylase deficiency. What happens in 11-hydroxylase deficiency? Okay, so even in 11-hydroxylase deficiency, you are not going to get formation of aldosterone and cortisol. But what happens is, there is formation of deoxycorticosterone, which has some function similar to aldosterone, and then you have 11-deoxycortisol, which has some functions which are similar to cortisol. Now, because there is an excess of mineralocorticoids, what happens is that this deficiency is not diagnosed immediately at birth. It gets diagnosed a little bit later on. Because of the excess mineralocorticoids, it leads to hypertension. Excess of glucocorticoids, it can lead to diabetes. And there is not much of, because cholesterol is being converted into precursors of glucocorticoids and mineralocorticoids, you might not get excess of androgens. Okay, so 11-hydroxylase deficiency, instead of leading to hypotension or hypovolemia, it instead leads to hypertension. Okay, now the next common or the least common is 3-beta-hydroxysteroid. So imagine what is happening in 3-beta-hydroxysteroid. This is again potentially a life-threatening condition, because the main block is here. Cholesterol is not getting converted either into aldosterone nor into cortisol. So if not diagnosed at birth, it is going to lead to death. The next few slides are very important for you from the exam point of view. So pause the slide, read the slide very carefully, because here I have given you structure of the various hormones, amino acids, here the number of carbon atoms that are present in mineralocorticoids, glucocorticoids, androgens, progestrogens, androgens and estrogen again, and what is the major physiological example of these steroids. The half-life of hormones is being asked very frequently in exams. So remember, half-life of FSH is 3 to 4 hours, LH it's 20 minutes, and growth hormone it is 10 to 20 minutes. Now these are tests for adrenal function. So remember, whenever you are suspicious of Addison's disease, the first test that you have to do is a 9 AM cortisol. Now, the basis of this test is that maximum levels of cortisol are seen in the morning. So, if the level of cortisol is 400 in a patient in whom you are suspecting Addison's disease, this is a normal level, so you are potentially ruling out Addison's. Whereas if you have a 9 AM cortisol of less than 100, it indicates that there is adrenal insufficiency and you are diagnosing Addison's. But if the level of cortisol at 9 o'clock in the morning, it is between 100 to 400, then you are not sure of your diagnosis, and in these cases then you have to do the synecthin test. Basically, synecthin is synthetic ACTH. So if after giving ACTH the levels of cortisol are raised, that means your adrenal is functioning well and you do not have adrenal insufficiency. Remember, the first test that you are going to do is 9 AM cortisol, because in NHS they always first do the basic or the most non-invasive tests. So if you are given a choice, the first test that you would do for adrenal insufficiency is a 9 AM cortisol. Now coming to Cushing's. Okay, so whenever you have any patient who is suspicious of having a Cushing's disease or a syndrome, always first do low dose DEXA suppression test, and if this test is positive, then you would do a high dose DEXA suppression test to localize the disease. That means you want to know whether it is basically Cushing's disease, which indicates that the disorder is central, or it is Cushing's syndrome where it is a peripheral disorder. So high dose is done basically to localize the disease. Low dose is done for your confirmation that the person has Cushing's syndrome. So these were the important points that you have to cover in endocrinology. I hope you have found the video helpful, and thank you once again for watching, and good luck for your exams.